All right, recording is started. So if there are no other questions before we get started, we're going to get started on the walkthrough of the question and answer document, which you should have received prior to today's work group meeting. I think it was sent out around the 25th of March to everyone. So this document was developed in response to the feedback that we received from the work group after the last work group meeting in February. It's currently organized into 4 sections. Section 1 here, it is confirmed template changes. So these are changes that we've already made to the quantitative data reporting template. Section 2 just details specific questions we were asked, and these are the answers that we're able to provide currently. It's quite lengthy. It is currently organized into questions specific to each tab of the quantitative reporting template. And then section 3 covers items that we're currently still determining how to respond to and how to put into the template. And then section 4 are items needing further discussion, and these are the 3 items that are already on the agenda for discussion today. So for the confirmed changes section right here, these are the confirmed changes we've already made to the template. So first, on the reporting info tab, we have added student as an option for the network market field. In addition, we've also added a field to identify all health benefit plans that apply to the network in that reporting tab, in that reporting info tab. On the exceptions tab, we have changed the label recent departure to departure or closure of a provider facility. And this was a request by a work group member, really to just more accurately reflect what's happening out in your networks, and then reflect historical information. For the providers tab, we have removed the Oregon counties served field. This was something we discussed, I believe, at the last work group meeting and also in the RAC. We removed counties served because we're already asking for zip codes, so it was duplicative. So we removed that, and we'll just be asking for zip codes. In the behavioral health tab, the number of enrollees assigned to or attributed to receive care from the specific provider, and then also the column that had unique members received was removed from the template. And this is because that language was removed from the rule. And so we also removed it from the template. And then the narrative fields. So we will, I don't know if this has already been done, Mark, correct me if it has not, but we'll be adding examples to the instructions and definitions section to clarify how narrative fields should be structured and what level of detail is expected.
That would still need to be implemented, yes.
Okay, so this is the one on here that has not been implemented yet, but will be. And then the exceptions tab in the mitigating measures column, it has been updated to allow carriers to select more than one measure they've undertaken to ensure enrollees have access to care without delay. And we also added a field that allows for you to write in a mitigating measure if it's not included in the list of dropdowns. So any questions about the confirmed changes? Hearing none. All right, I'm going to move down to the Q&A section. So like I said, this represents questions that we were asked in the feedback after the last work group meeting by work group members. It is organized so that there are questions that relate to each specific tab on the quantitative data template. So there's questions about the reporting info tab, the providers tab. There's also questions about time and distance specialty types, behavioral health, and also the behavioral health tab. I'm not going to go through all of these because, again, it is quite lengthy. I'm hoping that you all had some time to review this prior to the meeting. I will say that one of the things that we don't necessarily have answers on right now, because we're working towards that in the next work group meeting, is any questions related to how to report for appointment wait times and the secret shopper surveys. That's information that we are still currently working through and hoping to have a more in-depth conversation with the work group about, so it wasn't included. There are still many outstanding questions about that we don't have answers to. So does anybody have anything specific that they would like to bring up as it relates to this questions and answers section? Okay, hearing none. I'm going to move down to the third section, which is items that are currently under review. These are things that we're still trying to determine the best approach to. One of them is there were, in the feedback received after the last workgroup meeting, there were many requests to add specific definitions to the template. DFR, we're still reviewing whether or not to add, whether there are existing definitions within Oregon statute or rule, and if we should add those to the template. So currently, the request is to add definitions for appointment request, provider, specialty, telehealth provider, facility, network affiliation, network tier level, and then also reproductive health care provider. Like I said before, there are a number of items still under review as it relates to the quantitative measurements for appointment wait times and how to report those to the division, including, the secret shopper survey methodology, how that would work. We will be having a work group meeting, I believe it's on April 30th, to have a more in-depth conversation about secret shopper surveys and appointment wait time reporting. So I don't have any updates on this section right now, but hopefully we'll have a more in-depth conversation with the work group about this and have some answers for you after that meeting in April. And then for the enrollee count timeframe, we're still determining whether or not on that enrollee tab where you're entering the number of enrollees, whether or not you should, that enrollee count should reflect a specific point in time during the year or a snapshot from a specific date. And I believe when Mark walks through the template, he'll have some questions for the work group about this in particular today. So any questions, comments, feedback about this items currently under review section? Got a quiet group today, huh? All right, so moving on to section 4, items needing further discussion. These are the topics that I'm hoping we can have a more in-depth conversation about later today. One is, how should reproductive healthcare access information be reported to DFR? Currently, we have on the template reproductive healthcare listed in the providers tab, and there's been some comments, some feedback that reproductive healthcare doesn't necessarily belong on the providers tab because they are not a recognized provider licensure category, and they don't have a specific taxonomy code associated with reproductive healthcare providers. So the question is, how should we report for reproductive healthcare providers? The other questions are about how to include mid-level practitioners such as physician's assistants and nurse practitioners to the template. How should we represent those on the providers tab? And then the last is the rule does require carriers to conduct a geospatial analysis to demonstrate compliance with travel time and distance standards, and report those results to the department in the format prescribed by the department. We don't necessarily have a format in mind right now, so we wanted to kind of have a conversation with the work group about if you're reporting this information currently in other ways, and if there is a current format that would work to submit that report. So any last questions, comments, feedback about anything I've gone over so far? All right, we're going to move on to Mark, who is going to walk us through the changes to the quantitative data reporting template. I'm going to stop sharing. Mark, do you have the template to share, or do you want me to share it?
I have the template, so I'll go ahead and share my screen.
Thank you.
And just want to make sure everyone can see this.
Yes, we can.
All right, perfect. Thank you. So this is the most current version of the network adequacy reporting template. There might be a few minor changes from the one that you'll see from the one that we sent out in March, but just wanted to let you know about that. The first tab we have here is just a reporting information tab that gives us information about which company is reporting their NAIC code. Because we are asking carriers to report at the network level, we'll ask them to specify the name of the network and the network ID. And the information populated in these fields will also auto-populate in other tabs as well for ease of reference. There's a field for the network market to specify whether it's for individual, small group, large group, or student plans. And as Brooke mentioned, we recently added the field here for health benefit plans that apply to the network. And then fields for the date that it's being filled out, the reporting year, the person who will be the point of contact for this reporting, and their title, phone number, and email. So, does anyone have any questions on that before I move on to the instructions and definitions? Yes, go ahead.
Hi, this is Abby with Kaiser Permanente. The network market, can you select multiple options under that?
No, it is currently set up to only select one option at a time.
So our networks apply to multiple, I guess, markets, as using your terminology. We would need to be able to select more than one option per network. Speaking on behalf of Kaiser.
Okay, we can look into how to incorporate that functionality.
Thank you.
Make note of that. Okay, the next tab covers instructions and definitions. The instructions go tab by tab. And the intent is basically to allow carriers to know what DFR's expectations of them are when filling them out so that we can get the most accurate data possible and the most comparable data between carriers. It specifies certain fields for various tabs where we think that there may be questions or where there have already been questions before. Below that, we also have the list of definitions for various terms used throughout the reporting template. As Brooke said, we are still adding to this, and we will continue to do so, and as questions arise. Did anyone have any questions or comments on that before we move on to the actual data reporting tabs? Okay, I don't see any. So the first tab is for time and distance reporting. And this one is asking for the number of providers serving each provider specialty type for each county, as well as the number of enrollees meeting the CMS travel time standards and number of enrollees meeting the CMS travel distance standards. Because we are also asking carriers for the number of enrollees by county for each network being reported, we would be able to use that information to know if carriers are meeting the 90% thresholds necessary. Carriers can also report the number of telemedicine providers that are used to meet the access requirements. And again, this is broken down by provider specialty type per county in Oregon. Were there any questions?
Would it be by, sorry, this is John Armstrong from Aetna. Would it be by county or that serve county? Because you could have a provider serving multiple counties there.
Yes, so it would be the number of providers that serve the county. So if you have one provider that serves, one, let's say, cardiology provider that serves multiple counties, you would count them for each one of those counties.
Okay, thank you.
As you scroll down the list, we see that it covers each county in Oregon. So I see Gail's hand up.
Hi, this is Gail Manasco with Bra Society, and in reference to Senate Bill 1137, which is around plastic surgery, autologous breast reconstruction techniques that don't compromise the muscle, is because it's so specific, how will that be incorporated into this data template that seems to be a little bit more broader by specialty?
So are you saying that from the list of provider specialties here that the scenario you mentioned is not properly accounted for?
Right, because if you scroll down and if there's just plastic surgery or plastic surgeons, then they still may not be microsurgeons that can do the procedures listed in Senate Bill 1137.
Yeah, Gail, I understand what you're asking. These provider specialty types are broad because they are the provider specialty types that are indicated by CMS, and we used the same provider specialty types as the CMS list. So it doesn't get into that granular detail of the specific plastic surgery specialty types that would do those autologous breast reconstruction services in 1137. But I can add that to the list of things that we need to do a little more work on to kind of determine the best approach.
Thank you. I really appreciate it.
Go ahead, Melissa.
Yeah, so I heard what was said about how, like one, like let's say a specialty provider, like a cardiologist might serve multiple counties. And so how does that work with telemedicine? That was a question that I had from last time as well. Just trying to figure out how this is going to work, because we have a provider who resides in a county, let's say like I, for instance, see people both in person and also do telemedicine. And so I do that within my county. And then with the telemedicine, I might have some people in, I'm in Eugene, so I might have some people in Multnomah County. And then there's, of course, telemedicine only providers who could theoretically be located anywhere, not even in Oregon. And they might see people in many, many counties because they're only telemedicine. And so I just wanted some clarification around how that's counted and how insurers are supposed to be reporting on that.
Certainly, I can say that we are still working on the definition of scope for what is telemedicine providers for the reporting purposes.
Mm-hmm.
Whether it's telemedicine only, whether it's someone who has a physical location and does telemedicine. So we are still ironing out that detail, but
Okay.
we will also take that into consideration in terms of reporting for providers serving the county.
Okay. Thank you.
Yeah, and just to throw in there, Melissa and Mark, what we have asked carriers to do in the template is if it is a telehealth only provider, so they are only providing telehealth services and no in-person services, then in the county section, I believe they have the option to either select or write in virtual. But if it is a provider who provides both telehealth and in-person services, then we're asking them to include the actual physical county and not select virtual only.
Okay. That's helpful. Yeah. Yeah, it's just I imagine it's difficult to have this all figured out because again especially with telemedicine only providers, they could theoretically be serving every county in Oregon. I mean, theoretically.
Yep, you're correct. Yeah.
Okay. Thank you.
Yes, thank you for the questions. Our next two tabs actually are for exceptions. One is for health professional shortage areas. The other is for low income zip codes. There is a lot of, not necessarily duplication, there's overlap between the two and the information that we asked for. But for the health professional shortage areas, we asked carriers to report the reason for the exception. And this is a list that we got from the Health Resources Service Administration for primary care, health professional shortage area, dental, mental health, or medically underserved area or population. They can also report which county that is in. For low-income zip codes, carriers would simply report the low-income zip code that is being served. And for both exceptions tabs, they would also provide the provider specialty type, which is chosen from the drop-down list. They would report on the various standards that weren't met. So whether it was the time standard, the distance standard, or the wait time standard, they would mark whether it was true or false that that standard had not been met. They would provide the primary reason that the network failed to meet the standard. And some common options are provided here in this list: lack of available providers, lack of providers willing to contract, or a departure or closure of a key provider or facility. One could also choose other and fill in those reasons here as well. And further on, we are asking carriers if they have the documents available for contracting efforts to address the network gap. And then there's an option to mark whether there have been any mitigating measures, including use of telemedicine, identifying contracted providers in adjacent counties or service areas, or documentation of established contract management, referral, or transportation protocols. There's also space to fill in any other mitigating measures that have been employed. So, were there any questions on the exceptions tabs? Go ahead, Gary.
Yeah, just clarify when you want us to document our efforts, or excuse me, Gary Holiday, Pacific Source Health Plans. How far back is it? The past year, or when you're looking for documentation of our efforts?
That is a good question. We can discuss internally what the scope of that would be, and we will get back to you with an answer on that.
Okay, because I think if you go back more than a year, it might get a little challenging as companies do it. Maybe 2 years, but I don't know what other carriers are, but things kind of move quick.
And sorry, Gary, Can you repeat the question for me just so I make sure I write it down correctly?
For the documentation column, when it says, document our efforts, how far back is it, for the past year or 5 years? What is it where that's going to be relevant to what's going on here?
Got it. Thank you.
All right. The next tab to cover is the Providers tab. This is where we ask carriers to provide a comprehensive list of the providers and facilities in the network. If there are multiple providers in a given facility, we ask them to list out each one of those providers and their facility name. There's a field for the provider facility number, and for that one, we're looking for the NPI. There's also a field for their specialty, and again, this is a drop-down of the list of provider specialty types. We are also asking carriers to report each provider's or facility's street address, their zip code, and their contact phone number. Whether they are accepting new patients, whether they are located in or serve a low-income zip code or health professional shortage area, and what their network affiliations and tier level are, if that applies. Did anyone have any questions on this tab? Okay, I see none. So we'll move on there to the Behavioral Health tab. This is a tab that asks for more detailed information on behavioral health providers. So there would be some duplication in the sense of the names of behavioral health providers that were also listed on the Provider tab. But for those that are behavioral health providers, we are asking what their provider type is, such as licensed professional counselor, licensed marriage and family therapist, and so on. Whether they are accepting new patients, whether they serve children, adults, or both. And there are also several columns for the providers to self-report whether they can serve individuals of certain demographic groups, such as those with limited English proficiency or who are illiterate, those who have diverse cultural or ethnic backgrounds, individuals with chronic and complex behavioral health conditions, or individuals who identify as LGBTQIA+, or with diverse gender identities or sexual orientations. And carriers have the ability to say whether the providers just reported yes, no, or did not provide a response. For instances where a provider did not provide a response, we do have a box up here for carriers to provide more context around those providers that did not give the information that was being requested. We are also asking for the behavioral health provider's county and zip code. And these, much like the ones on the Providers tab, if they are telemedicine only, a carrier can simply enter virtual in those fields. Does anyone have any questions on this tab before we move on? Okay, I see none. And, I see a hand.
Sorry, I was late on the clicker. This is Kylie from Providence Health Plan. On this one, what kind of metrics are you expecting to see? So like, what if 100% of our providers refuse to answer one of these questions? Is there some sort of like quantitative amount of answers you're hoping for on this? Is there an adequacy metric that we should be trying to meet with these questions?
That's a great question, and the answer is no. We don't have a current adequacy measure either in the rule or the statute or really in mind for this particular section. We know and we've heard of the challenges both on the provider side and the carrier side in getting some of this information and the limitations that you all have. And so really, we're just hoping at this point to get as much as we can, especially in the first couple of years of reporting, to see what the baseline is. And then, you know, as we move further into further years of reporting, see, you know, if anything here needs to be adjusted. But right now, it's just really the most information that you can get.
Okay, great. Thank you.
Any other questions? Okay, moving on to the enrollees tab. This is where carriers would enter the number of enrollees by county for each network that is being reported on. And as Brooke said, we are still working through the best approach for this, whether it would be a snapshot in time or whether it would be number of carriers or carriers, sorry, total number of enrollees that had been on the plan throughout the reporting year. We are still engaged in those conversations. And the last tab is really just here for reference purposes. It is the base time and distance standards for each county classification: large, metro, micro, rural, or counties with extreme access considerations, and each of the provider specialty types. And there's nothing that carriers need to do for this tab. It's simply there for an easy, quick reference. And that is the current state of the network adequacy reporting template. Were there any other questions at this time? Go ahead, Gail.
For the large metro, micro, rural CEAC, is there a list of like zip codes or cities to know which one it falls into?
There
Yes.
is. So go ahead, Brooke.
Yeah, there is, Gail, there's both a list of low-income zip codes and health professional shortage areas. And then if you go back to the providers tab, I believe it is. Oh, here we go on time and distance reporting. All of the counties here that Mark has in the template have the county classification listed next to it. So it'll say whether it's a county with extreme access conditions, a micro, a rural, a metro county, and those are based on the 2025 CMS definitions.
Great.
Mhm.
Great.
And
And
I
the
will-
distance
go ahead, Gail.
would be miles and the time would be minutes?
For time and distance standards, correct, yes.
Okay. Thank you.
And I did just also want to mention the version of the template that was sent out to the work group also includes, in addition to the base time and distance standards tab, there is an alternative time and distance standards tab that's included. We removed that from the template because the base time and distance standards are a static point in time. They're frozen to that January 1st, 2025 point in time that the statute references. The alternative time and distance standards, the rules say that carriers can use alternative time and distance standards from CMS for that plan year. So those will change on a yearly basis. So instead of adding them to the template, we're going to include them in the yearly bulletin that we have to write that includes also the yearly low-income zip code list, and also the yearly health professional shortage area list. So the bulletin will include references for all three of those now: the alternative time and distance standards for that year, the health professional shortage area list for that year, and also the low-income zip code list for that year. Yeah, go ahead.
Oh, and then what about the wait times?
The appointment wait times are in rule, so they have specific times associated with them. For primary care, I believe it's 10 days. Don't remember off the top of my head, but they
But
are.
would that be in the workbook or in the template?
No, it's in the rule, so they're not going to
Okay.
change, so that those are in the rule. And it does say the associated time and distance, appointment wait time standards for primary care, behavioral health, and specialty providers, specialty care providers.
Thank you.
Were there any other questions at this time? All right, I'm not seeing any, so I want to thank you, everyone. I will hand it back off to Brooke.
All right, thank you, Mark. So we are flying through the agenda, which means that we hopefully have plenty of time for our open discussion to talk about the three topics that we wanted to get a little more clarity from the work group on. The first is reproductive health care reporting. As you saw in the Q&A document, we are required to collect information on reproductive health care access. The carriers are required to cover reproductive health care under REA, and then for network adequacy, they're required to have a network of providers sufficient to meet the needs of enrollees, and that does include reproductive health care providers. So the division does have to collect information on reproductive health care providers and the ability for carriers to meet the needs of enrollees as it relates to reproductive health care. Our current draft of the time and distance tab in the quantitative data reporting template includes reproductive health care as a specialty row. And like I said, we have received feedback that that doesn't cleanly fit there because they're not a recognized provider licensure category, and they don't have a taxonomy code associated with reproductive health care providers. So we're exploring whether it makes sense to remove reproductive health care from that tab and have it reported through a different mechanism. So the question for the group really is, if we remove reproductive health care from the time and distance specialty list, where does it make the most sense? Where does it make the most sense to capture that information, and how does it make the most sense to report that information to the division? Antoinette.
Oh, hi, this is Antoinette from Cambia Health. I just wanted to make sure that I understand this. So does the DFR also acknowledge that there isn't any, I guess, there really isn't any specialty providers that fit under that? Or I guess a better way of maybe stating that is there isn't any specialty codes that fit under reproductive health? Because when you look at the REA mandate, the Reproductive Health Equity Act mandate, it doesn't really own in on provider types. All it really addresses are the screenings and the services that must be provided under that mandate. So is the DFR acknowledging that there really isn't, or they are unable to specify the specialty type, I guess, a provider that qualifies under reproductive health? And therefore, at this point, the DFR is trying to determine whether to remove that from the template and address it at a later time or elsewhere outside of the report, network adequacy report.
So, okay, first, I think that this is a difficult topic because my understanding is that a reproductive healthcare provider can be any type of provider who is providing reproductive healthcare services to an enrollee. And that could encompass a number of different provider types, right? You could have a primary care provider who is providing reproductive healthcare services to a enrollee. You could have an OBGYN. There are a number of different provider types that could fit under a reproductive healthcare provider if they're providing reproductive healthcare services. So it makes it very complicated because there's not necessarily a good definition for reproductive healthcare provider, and because it encompasses so many different specialties. However, the network adequacy statute itself, it does require specifically the division to assess networks as it relates to their coverage of reproductive health. And so in this network adequacy reporting, we do need to be collecting information about carriers' network of reproductive healthcare providers. And so I don't know if that answers your question, Antoinette, but I guess we're struggling along with you about what is the best way to capture that information, since there isn't necessarily a set in stone provider type that is associated with reproductive health care.
I guess my fear with it being so broad of a category is that I don't want commercial payers to be dinged if they don't capture a provider that the DFR just automatically assumes provides reproductive health. So just kind of at least maybe trying to identify a category, whether it's OBGYN, because really with the REA, the DFR really never did any rulemaking on it. Mm-hmm. It followed up with a market conduct examination, and then followed by a bulletin that really did not address, the provider types. So basically, if a member went to go see, like, I don't know, this is maybe not the best example, but it could happen. Went for their colonoscopy, for example, and had a question regarding, reproductive as a result or something like that. I mean, does that provider qualify as a reproductive health because they provided advice, on that, or feedback on that? It's just that it's nice to have some kind of structure or a list that the DFR will consider as a provider providing reproductive health. Because again, I don't want commercial payers to be dinged because they didn't capture that.
Okay, so are you saying, Antoinette, that it would be helpful for the division to provide, like, here are the types of providers that generally provide reproductive health care that we would consider generally providing reproductive health care?
Yeah,
okay.
Yeah. So at least we have something to work with rather than it being so broad. Yeah.
That makes sense. And Lisa did just point out that I believe OHA has some categories of that lists different types of reproductive health care providers that we may be able to pull from. So we'll take a look at that and see what we can do in that area, Antoinette.
Great. Thank you so much. Really appreciate it.
Mary, go ahead.
Hi, Brooke. Mary Brown from United Healthcare. Kind of echoing what you were saying about how the reproductive health care isn't a CMS-defined provider specialty. I was thinking about this one, and I was, looking at the regulation, and basically what I felt might be good would be if we did an attestation that would allow carriers to affirm that reproductive health care services required under the DFR are covered and accessible. And then that way we can also attest that enrollees can obtain their services through in-network providers or any other permitted arrangements. And then we could also put in any known access gaps as well in what our measure, what we're going to be doing with those gaps. So that way we would meet the statutory requirements, but we wouldn't have to lump, a bunch of providers under something that's really not a defined provider specialty.
Yeah, that's an interesting idea, Mary. I appreciate that, and that's something that I think we can look into, whether that's a potential solution here.
All right, thank you.
Antoinette, did that bring up something for you?
Yeah, I guess I want to, I have some, concerns with the attestation route. Again, another form we need to fill out. But I thought that going forward with certain reports, the DFR is going to require that attestation that is now required of certain of reports where we have to attest that the data pulled is accurate, and then who our technical person pulled it, as well as our compliance person. I thought that was going to be required. And is that going to be the form that is used to attest to this if the DFR goes this route? I still want to, given the outcome of the implementation of REA without the DFR's rulemaking, again, it would be nice to have the DFR identify for us, even through the OHA list of who qualifies, which provider types qualified as providing reproductive health. It would be nice to have that list for us to work off of, for our reporting. So again, with the attestation, I would like to clarify, is this the attestation that the DFR currently has, that it's required to accompany certain reports, or would this be a different attestation if the DFR goes that route?
So I don't know what reports we currently require attestation for, Spencer. Is that something you may be able to answer, or do we need to table this and come back?
Hey, this is Spencer Peacock with DFR. Yeah, many of our annual health insurance reports include that attestation. Antoinette, you raise a good concern. I think it's too early to say, right? I think we're still looking into what the appropriate solution is here. I can totally acknowledge the concern with having multiple attestations that you're filling out, and how detailed do they get. So I think the answer is more to come. And hopefully this is something we as a division can take back and pretty promptly get some more clarification for all of you on. That's what I have.
Awesome.
Thanks,
Thank you, Spencer. Gary, go ahead.
So for listening to Antoinette, and right, are you trying to evaluate or measure us against the number of providers, or is the access? Because I agree with Anna, REA is very broad, and we basically would just throw all our providers in there, just the way it reads. And so are you trying to measure access, or just the number of providers that can do reproductive health? And that's what I'm trying to understand as I think through this.
We're trying to measure access. So the requirement is that that carriers have a network of reproductive health care providers that's sufficient to meet the needs of enrollees. And so we're really trying to ensure that that is the case, that there is a sufficient network of reproductive health care providers to meet the needs of the enrollees.
Right. And what I'm thinking through this is the way that REA is being interpreted by the state. It's so broad, basically all our providers would essentially be put in there. So that's why it'd be hard to say, hey, we're not in compliance with that. That's what I'm trying to think through, is how you do this.
Exactly, because from what I'm hearing you say is that any type of provider may be a provider that is, I'm saying providing a lot, but providing reproductive health care services. And so they could be considered a reproductive health care provider.
Yeah.
And so, yeah, I get what you're saying, Gary.
Okay.
And I don't have a good answer for you right now, but I think that we need to take back the information we've gotten today and kind of have an internal conversation about what the next step is. Spencer, go ahead.
Yeah, anyone who's been on a call with me is you've all heard this before, but number one, thank you, right? This is certainly a conundrum we're trying to figure out as well. I think the answer is there is no clear-cut answer, right? On our side or on your side. I suspect your systems don't have a little checkbox that says, oh, yep, this provider offers reproductive health services. So in that world, you providing the feedback is super helpful because at some level, our policy team is going to have to be able to communicate. We understand this is what the statute says and what we're obligated to do. We got to figure out how to do it. And, legislature, give us some additional guidance on it. Or somehow we have to be able to communicate that as well, right? I think we'll do our best to give you something to run with, but I think we can also acknowledge we're not going to come knocking on your door saying, hey, you didn't include this provider and we think they should be included, right? We've got our hands full just trying to work through this in general. First year we're diving into this. There's going to be a lot of lessons to learn, and we're here to work with you.
Right. So Spencer, one way to think about this is if we want to really just look at the doctors in that fashion, I mean, I'm supporting Antoinette. We're going to need rulemaking to decide and decipher some of that or put them into categories, and then we can do the data call and work through it that way. Because again, the way we went through the exam and way RIO was being interpreted it's so broad. I don't know if there's much value in saying, all right, identify all your providers who can do reproductive health care.
Right. This may be a scenario where we basically say, we can't give you what you asked for, but we can give you something that's close. And so we went this route, we made these decisions, and this, it's not exactly answering your question, but it's helping us get more clarity on it.
Yeah, no, I appreciate it. That's why I was just trying to think what Brooke's asking here, and I don't know if necessarily counting doctor heads are going to solve it. Okay, thank you.
Thanks, Spencer. Thank you, Gary. Any other thoughts about this topic? All right, hearing none, but I don't think this topic is going away. We have some more thinking to do on it, and I'm sure that we're going to be bringing this back to the work group in some fashion at a work group meeting in the future. So more to come. We'll do some internal thinking and then we'll get back to you. So the second topic is how to handle mid-level practitioners, specifically nurse practitioners and physician assistants in the template. The core issue is really that NPs and PAs can, again, practice across a wide range of specialties, just like reproductive healthcare providers. And there isn't a single taxonomy code or specialty designation that covers them cleanly. If we do list them under a specific specialty, we could be undercounting their contribution to network access. And if we don't include them at all, we may be overstating gaps. So the question for the work group really is, how should NPs and PAs be included in the template, and how should their specialties be categorized? So here are some things we thought about just to jumpstart the conversation. So one, should NPs and PAs be listed under the specialty they primarily practice in, even if their taxonomy code doesn't match the specialty label in the template? Should there be a separate row or designation for NPs and PAs, or should they fold into the existing specialty rows? And are there specific specialties like behavioral health or primary care where this issue is particularly acute for you and your networks? So happy to hear any thoughts that anybody has.
The QHP standards, they call out nurse practitioners specifically for primary care, for adult and pediatric. So just adding those in that category would probably scoop up the majority of ours. I know that sometimes with our OBGYN, sometimes we lump the NPs in there depending on their title that they have. Same with psychiatric nurse practitioners. We lump them in based on their title, their designated medical license title, letters.
Thank you. That's helpful. Does that make sense to other carriers on the call? The way that QHP is including them in the primary care, in adult pediatric, and the way that they're being lumped in to other subspecialties as it relates to their title? So if we decide to go that route and say that's how carriers should be including information about nurse practitioners and physician assistants, is that going to cause any issues for any of the carriers on the call?
Could you please restate how we would count that?
So for QHPs, they're including them in primary care and oh, sorry, Kylie's putting it in the chat here. So let me pull it up so I sound. Okay, so QHP, they have them listed as primary care advanced practice registered nurse, primary care advanced practice registered nurse adult, pediatric, and then behavioral health advanced practice registered nurse. And then Kylie also said that they are NPs and NPAs are being lumped in to specific categories such as reproductive health or behavioral health based on their titles. So the title that they use, whether it's, I don't know, behavioral health nurse practitioner.
Yeah, I'm blanking on all the letters too. Like
NP, I don't know what they are, NP, LMP, and T, all those, yeah.
So in this scenario, could you have an NP that is you're lumping in with cardiology because that's their area of focus?
Yes, I assume, yes, if you had an NP that their area of focus was cardiology.
And maybe that's a bad example, but you get what I'm, outside of, excuse me, outside of these categories, they could still be counted if they have a particular area of focus that aligns with a different specialty.
Correct.
Yeah. Okay. Thank you. I just wanted to make sure I heard that right. That no concerns from me.
Okay. All right. If that makes sense, I'm going to move on unless anybody else. Gary, go ahead.
Yeah, I think it depends, Brooke, of what kind of analysis you're going to do. Does it matter in your analysis if we get this detailish with the providers or not? Or is it you just wanting head counts? Or do you want to really focus in on NPs and, that level? And that may be the question is up to the division. How much do they want to get into this?
Yeah, that's a good question, Gary. I don't know that I have a great answer for you right now. My off the cusp reaction is I don't know that we want to get that granular and have exact counts of PAs and NPs, but that's probably a question that I need Cassie's input on. And unfortunately, she's not on the call today, so I will take that back.
Right, because I think, at least for physician resource, I think we can, put them in there if it gets, to your analysis. But if the practitioners are going to get upset because they're being combined, that would probably be the more concern how I would see it than the health plans.
Okay. Any other thoughts? Okay, I'm going to move on to the last topic, which is the format for submitting the geospatial analysis results. So under the rules, carriers are required to conduct a geospatial analysis to demonstrate compliance with time and distance standards and to report those results to DFR. The rule also states it should be in the format prescribed by the department. We don't currently have a format in mind, and so we wanted to bring this to the work group to kind of have a discussion about what format works best for submitting geospatial analysis results. Is there a format that you're already using that we could use in this instance? So any thoughts that anybody has, that would be helpful. And Tiffany, go ahead.
Yes, so I'm Tiffany from Cambia Health Solutions, and we use Quest Analytics to produce our geo access reporting. Is that something that would be acceptable?
Are they, is it like a separate report that they're sending to you that is just the geospatial analysis results?
We actually produce them on the application ourselves. We own the software, so we're able to produce the reports in-house. And so we could produce the report and send it to you in that format. And there's several different formats. There's an Excel spreadsheet that has the data on it, or we can produce a map.
Is it possible for you to send us an example of those, Tiffany, of what it would look like? Because I have seen, the Quest Analytics template that they use for some of the data collection related to network adequacy, but I haven't seen that particular geospatial analysis report. And so it would be helpful to kind of see what that would look like to see whether or not it would work for this purpose.
Okay.
Gary, go ahead.
So to help us, do you have thoughts about the content requirements of a geospatial analysis? Because I think there's different vendors out there, but is there certain data elements that's going to be required in it?
That's a good question, Gary. And I don't know that I have an answer for you right now. What data elements?
Because it may be something we do in-house, or if we want to continue to use a vendor is what I'm thinking.
All right. I'm going to get back to you. We're going to talk about that internally and we'll get back to you, Gary. Abigail, go ahead.
Yeah, thank you, Abby with Kaiser Permanente. Yeah, I had a similar question. I know this template that you're getting at is going to give you an idea of, whether there's network adequacy gaps and should give you an idea of where the gaps are. So I was curious, what are you looking for above and beyond that in this I'm sorry, what did we call it?
Geospatial analysis.
The spatial, thank you. What are you looking for above and beyond with this geospatial analysis that you can kind of help us understand so we can figure out what that might look like?
Yeah, and so this is something that CMS requires, and unfortunately CMS requires of their QHP marketplace, and I am not as knowledgeable as I probably should be on what that looks like for the CMS, for the QHP marketplace. I think what the information that we're trying to get out of this is, really, are you meeting the time and distance standards? So are enrollees located within those specific quantitative measurements for time and distance that CMS has associated with their January 1st, 2025 rules. So I don't know what that looks like, but I think maybe we need to do a little more work in this section to kind of give a more clear picture to carriers what exactly it is the division would like to see from this. Does that kind of make sense?
Yeah, that sounds great. Thank you.
Okay. Any other thoughts? Okay. So that is the end of the open discussion section. Next, I think we had next steps. So we do have another work group meeting coming up April 30th. We don't plan to make specific changes to the template and send them out before that April 30th meeting. So I'm curious what people on the call in the work group think about how long you would want with the template before providing feedback. Do you want a month with it? Do you want, 2 weeks? What would be beneficial for you all for a comment deadline on the template?
Do you mean before the next meeting on April 30th?
Yeah, the April 30th meeting isn't really going to focus on the quantitative template, so I don't think we need comments or feedback before that meeting. Really, we're probably going to add we will add another meeting in May where we'll focus again on the quantitative template and any changes that we've made. So I'm just curious, like, what you think is a good feedback time frame. And it doesn't have to be before April 30th.
And when are we, or when is the DFR hoping to basically finish work on the template? And that may drive, I guess, my opinion as to when the time frame the DFR should give us to respond or to provide feedback.
Yeah,
based
our
on the
original goal was to have the template completed by June or July of this year to give you all plenty of time to work with it, establish whatever contracts you need to, if that's the case, and then provide us that data in March of 2027.
Okay, and we're already in beginning of April, so a month would be May. I mean, I wouldn't mind about like 2 weeks or 3 weeks, because we will be providing you a sample of the question analytics, and I'm sure the DFR would need time to review it before determining whether we can use that to support that reporting requirement.
Okay. So 3 weeks is April 29th. Does that sound okay to everyone?
Yeah.
Okay. All right, so feedback on the template or the Q&A document, any feedback you want to provide to us by April 29th. We will be having another work group meeting that focuses on the appointment wait time reporting and secret shopper surveys on the 30th. And we'll be providing you with more information on that, hopefully next week or the week after. And then we will be adding another work group meeting in May to discuss any changes to the quantitative template and any additional questions that come up in the feedback. And then I also have for today, I have a number of notes regarding the conversation today that I will send out to the group after the work group meeting. Anything else I should think about for next steps? All right, well, I'm going to give you some time back. Thank you all for the conversation. We really appreciate it, and look forward to your feedback.
Thank you, Brooke.
Thanks so much, Brooke.
Thank you.
Thanks.
Spencer. Bye.
Thank you.
Thank you.